I'm just going to run through a couple of slides from the presentation that will be at the plenary session today, and it's my pleasure to tell you about the first results of this randomized phase 2 trial in women with metastatic breast cancer who have a form of breast cancer called triple-negative breast cancer. And this is a randomized phase 2 trial of chemotherapy alone, which is a standard regimen, gemcitabine carboplatin, with or without a new agent, an intravenous drug called a PARP inhibitor, BS-201, which I will explain to you. So triple-negative disease means that the breast cancer does not have the estrogen receptor, the progesterone receptor, or HER2. And these are three receptors that we very commonly target in patients whose breast cancers express them. And we really don't know the molecular etiology and the driving forces of the triple-negative breast cancer, so we don't have a targeted therapy for this type of breast cancer. It comprises 15% of breast cancers, and BRCA1 associated breast cancers are nearly always triple-negative. And this is a highly proliferative, aggressive form of breast cancer. The good news is that about 70% of women who have early-stage breast cancer and who get adjuvant chemotherapy do not have their disease recur. So in fact, it is a highly curable breast cancer for the majority of women. However, about 30% of women will suffer a disease recurrence. And once they develop metastatic breast cancer, their lifespan is only about a year or so. So and our therapies don't work particularly well, our chemotherapies don't work particularly well for this type of breast cancer, and lifespan is short. Now, we, of course, have been doing a number of clinical trials trying to advance the treatment options for this triple-negative metastatic breast cancer. And one agent that makes a lot of sense to try are these PARP inhibitors. PARP inhibitors are enzymes in the nucleus of the cell that are involved in DNA repair, a particular kind called base excision repair. And it turns out that in triple-negative breast cancers, we believe that they're very similar to these BRCA1-associated breast cancers, and they've lost the ability to repair double-stranded DNA breaks. And when they've lost that ability, they're reliant now on single-strand DNA repair, and that's where PARP comes in. And so most triple-negative breast cancers have a lot of this PARP enzyme because they've lost the ability to repair double-stranded breaks. And so BS-201 is an intravenous agent. It inhibits PARP in the nucleus and inhibits DNA repair, and it definitely potentiates the cytotoxic activity of chemotherapy such as the platinum. So we were very interested in a platinum-based chemotherapy for this trial. Interestingly, and kind of very different than we're used to in the cancer world, the BS-201 does not add any toxicity to chemotherapy. So that was a real bonus. In this small randomized phase 2 trial, 120 women with the metastatic triple-negative breast cancer were randomized to receive the standard chemotherapy, day 1 and day 8, on a 21-day cycle, versus the same exact chemotherapy with the IV BS-201 given days 1, 4, 8, and 11 every 21 days, with restaging every 6 weeks. Women who are randomized to chemotherapy alone, at the time of their disease progression, they were given the opportunity to continue on the chemotherapy and have the BS-201 added to their regimen. And the main findings are the progression-free and overall survival from the trial. And you can see here that the progression-free survival more than doubled from 3.3 months on average with the chemotherapy alone to 6.9 months with the addition of the BSI. And you see the p-value there. It is highly statistically significant. It was about a 65% reduction in the risk of progressing. And then most importantly, and the reason this is a plenary session today, is that the overall survival, which was not the primary endpoint of the trial, but this is a comparison that looks at the two arms, and we see that the survival went from 5.7 months with the chemotherapy alone to 9.2 months with the addition of the BSI. Again, about a 60% reduction in the risk of cancer death in this small randomized phase 2 trial, and that is statistically significant. And so we've concluded that PARP1 was upregulated. There was extra protein expression in most of the triple-negative breast cancer patients who we've assayed for on this trial. The BSI-201 with the chemotherapy is very, very well tolerated. We couldn't discern any additional toxicity from the BSI being added to the gemcitabine carboplatin. The clinical benefit rate, which is an objective response, which is a 30% reduction in tumor volume or stable disease for at least 6 months, just about tripled with the addition of the BSI-201 to the gemcitabine carboplatin, as did the actual objective response rate. And then summarized here are the progression-free and overall survival. The primary endpoint of this trial was clinical benefit rate. So we do plan a large phase 3 trial that will start, we hope, later this month to really basically recapitulate these results in a much larger population, again allowing the patients to cross over. About 40% of the patients randomized to chemotherapy alone did cross over to receive the BSI-201 to date. So I'll be happy to answer any questions at the question.